This morning, I am very excited to introduce our own Chief Resident, Stephanie Peace, who will be presenting Grand Rounds this morning. Stephanie received her undergraduate degree from Harvard in organismic and evolutionary biology, as well as a minor in global health policy. She received her medical degree from the University of Missouri School of Medicine. Here at UW, she has been one of our global health track residents. Global health has been a longstanding interest of hers, and she has performed significant work internationally in Malawi, Mali, Ghana, Sierra Leone, and Uganda. We are lucky to have her this morning to share some insights on global health at this time.
Thank you so much, Dr. Vito, for that kind introduction. So this morning, I'm excited to be able to talk to you all about a little bit about something that we're all kind of dealing with in terms of our changes to the way that we are operating in medicine these days with COVID by using some case studies looking at Ebola, a prior epidemic that certainly didn't hit the US the way that COVID has, and then kind of transitioning to looking at COVID, specifically focusing on obstetric care. There we go. All right. So a little bit about kind of our plan roadmap for the morning. First of all, we're going to, as I said, talk about obstetric care and maternal health specifically in a global health context, utilizing the two case studies of Ebola, specifically during the epidemic that happened in West Africa from 2014 to 2016. Which made pretty big news, especially as some of those cases ultimately came to the US as well, obviously in a much more limited fashion. And then secondly, using the impact of COVID-19, specifically with a focus on low and middle income countries this year. Although at the end, we'll kind of transition to talking a little bit about what we can learn kind of from these pandemic responses globally. We'll talk a little bit about the roles of the healthcare team in pandemic response situations. And then, as I said, identify some implications from these responses and strategies in underserved and high-risk populations in the US. I have no disclosures. So as Dr. Bizzuto mentioned, I have done a little bit of work in a couple of different places in the world. This morning we'll focus on kind of as our preamble to the talk, the time that I spent in West Africa. So in 2011, after finishing my undergraduate degree in organismic biology that is often mispronounced, you can understand why, I moved first to Bamako, which is the capital city of Mali. And that was where I had really my first lesson in flexibility and adaptability in global health. As there was a military coup that destabilized the government and ultimately forced us to move to Sierra Leone. The capital city there is Freetown, which is where we lived when we were there. Freetown is it's a large city with just over 1 million people, crammed into a very small space, more densely populated than New York City. It is a place that is very resource dense, which has attracted a lot of attention from China and from other kind of global powers, especially in light of its kind of recovery from a civil war that happened in the early 2000s and late 1990s. So by the time that we arrived in Freetown, it was a fairly stable place, especially compared to where we had just come from, and also a very beautiful place with some of the most beautiful coastline and beaches, I think, of anywhere in the world. So while our life in Sierra Leone didn't always look quite like this, it often looked like battling generators in a place where there are rolling blackouts and brownouts kind of throughout the year, and a place where there's really incredible rainfall that will cause mold to grow on your shoes overnight. It did sometimes look like weekends spent on these beautiful beaches. Sierra Leone and Freetown in particular also look like this in other areas. As I said, it's one of the most densely populated places, and a lot of people in Sierra Leone, because of kind of rapid movement at the time of the Civil War from more rural areas to more urban settings, live in kind of slum areas with very dense population. At the time that Okay, sorry about that, technology. At the time that we had moved to Sierra Leone in 2012, Freetown was kind of in the middle of a cholera outbreak. It was the peak rainy season, and at that time there were more than 1,000 cases per week in Freetown. Obviously, Sierra Leone faces significant environmental risk factors for cholera and other kind of infectious epidemics, including, as I mentioned, a rainy season that averages 30 inches of rain during the heaviest months. This incredibly high population density, as you can see here, limited public sanitation and infrastructure, and then lack of access to healthcare. Freetown responded actually very rapidly to the cholera outbreak with huge public health campaigns, kind of partnered with the WHO and other multinational health organizations like Médecins Sans Frontières, Doctors Without Borders. In addition to the messaging, kind of public health messaging about safe drinking water and hand washing and things like that, one of the other kind of things that they put into action pretty quickly was mandating house cleaning every Saturday morning in one of the largest slum areas, which is called Crew Bay, which is pictured here at the top. And so every Saturday morning, residents were mandated to clean their house for 4 hours between 8 and noon. And that was something that was enforced, and they kind of went through the area. They had volunteers that would go through the area to ensure that people were doing that. We left Sierra Leone in 2013 when I started medical school, which incidentally was just under a year before the first Ebola patient arrived in Sierra Leone. Okay. So the Ebola outbreak that we're going to focus on, again, is from 2014 to 2016. And the primary focus there is Liberia, Sierra Leone, and Guinea, which were the 3 most affected countries. And again, we'll focus a little bit more on Sierra Leone just because it's near and dear to my heart. So Ebola is a single-stranded RNA filovirus. It is kind of a cousin to the Marburg virus, which has been a little bit more studied in some ways than Ebola. Both are considered hemorrhagic fevers, although this terminology is used a little bit less now, as patients often don't have the kind of classic hemorrhage symptoms until late stages of the disease when they're already in shock. The early symptoms of the virus, as pictured here, are pretty innocuous, headache, fatigue, fever. In places like Sierra Leone, where malaria is endemic, this is pretty unremarkable. This sounds like malaria, and malaria is often treated without testing confirmation. And so you can understand how it would make it a little bit of a delayed understanding or reaction that these symptoms are something more concerning. These symptoms kind of transition to the sudden high fever, vomiting of blood, and kind of progress onto the more severe stages rather rapidly from that point. The reservoir is a little bit debated, but in general has been considered to be bats, although that is more studied again in Marburg than it is in Ebola. There have also been documented cases from exposure to infected chimps and gorillas. Sierra Leone does have a fairly large chimpanzee population compared with Democratic Republic of the Congo, which also recently had an Ebola outbreak that actually has just finished, where gorillas are more kind of a potential source of infection. Transmission is primarily droplet via infected body fluids, but contact has also been identified, and then certainly there's significant nosocomial spread. One of the kind of challenging things during the West African epidemic is that burial rituals are very important culturally, and are also a potential source of, a time when lots of people are gathered together. They're potentially touching or interacting with the body of the deceased in ways that are concerning for contamination and spread. As with most viruses, there is increased spread in larger families or in older and sicker patients that have kind of other comorbidities. In terms of infectious body fluids, blood is the most infectious, but then it's also present in urine, semen, even up to 3 months after, sweat, breast milk, etc. So really it kind of goes everywhere, but again, blood is kind of the biggest issue. In terms of nosocomial spread, there was one case report from Sierra Leone that included spread to an entire surgical team as they were doing an XLAP on an infected patient that was not known to be infected at the time. So very, very challenging for healthcare workers in this setting, trying to maintain appropriate protective equipment. There's some question about whether aerosolizing events can also be a source of spread. There are none that are currently documented in humans, but there have been labs that have identified this in non-human primates. So probably there's some aerosolizing spread as well. Incubation period is from 2 to 21 days, and the case fatality rate is from 25 to 90%. So that's obviously a wide range. In the epidemic in 2014 in West Africa, the case fatality rate was around 50%, although in pregnant patients, it really is documented as high as 90 to 95%, and there has not been any case of fetal survival in the setting of an infected pregnant patient. So just to kind of zoom in, the history of Ebola epidemics really have mostly been in Central Africa since the 1970s when it was first identified. And so you can see here that the Democratic Republic of Congo, Sudan, Uganda are all kind of in the area where where Ebola has been a little bit more common, although these have been smaller outbreaks. The outbreak in 2014 in West Africa was both the first in West Africa, and so you can see over here, Guinea, Liberia, and Sierra Leone in the kind of yellow-orange. And it was also the largest outbreak that had been documented. There were an estimated 28,000 cases and 11,000 deaths during this outbreak. And then this chart over here just kind of describes, the patient 0 was a 2-year-old child, and you can see kind of the quick spread to the patient's family members, and then really rather quickly to healthcare workers, both midwives, physicians, and then further on to those people's family members. So you can see the hospital setting was rather quickly, or the healthcare setting at least, was rather quickly a source of spread here. So just to touch a little bit on what maternity care looked like in Sierra Leone pre-Ebola, because it's an important thing to kind of set the scene for what Ebola did to change that. Sierra Leone is a place that has the highest maternal mortality ratio in the world, with 1,360 maternal deaths per 100,000 live births. And the lifetime risk of death related to childbirth in Sierra Leone is 1 in 17. So very, very high. And part of that, although certainly not all of it, is that the relatively low rate of births that are attended by a skilled health personnel. Most rural women utilize traditional birth attendants that often have no formal medical training and certainly don't have any resources to care for obstetric complications or emergencies. Physician density is also among the lowest in the world at 0.03 per 1,000 of the population. Only Malawi and Somalia are lower. So really Sierra Leone is a place that has a lot of work to do in terms of, when we think about meeting sustainable development goals for global health. So this is a chart. You may have seen some of these types of charts from an organization called World Mapper. And essentially what they do is adjust the land area of the country to reflect the, the proportion of, in this case, physicians working. It's actually very interesting. You can go check it out. They have a lot related to COVID as well, in terms of mortality rate and things like that. So it's a very interesting way of looking at kind of picturing the world. And so here you can see that, the US in kind of light purple is fairly overrepresented in terms of physicians working, whereas Africa all but disappears. And that's consistent with kind of in Sierra Leone really not having significant physician coverage, or even, if healthcare workers are broadened to include midwives and nursing staff, it really still is very minimal. By contrast, this map shows epidemic deaths from 2001 to 2017. And so you can see here that the US all but disappears, as does really Europe and Asia significantly disappears. And really Africa is the kind of bloated area. It will be interesting, I think, to see how this graph changes if we were to look from 2017 to the next 20 years, because I think COVID is going to dramatically shift this a little bit, as we'll see. So looking at maternity care in Sierra Leone post-Ebola, their health system, as we've discussed, was already fairly weak, with limited resources and limited access to care for patients. And the health system was ultimately unable to keep up with the increased demand caused by the Ebola epidemic. There was a significant lack of confidence from patients in the healthcare system and fear of doctors and hospitals. There was a sense that hospitals were very often where people went to die. There was concern that physicians were injecting patients with the virus. In Sierra Leone, there's a big culture around medical things really being caused by witchcraft or by sorcery that may not be related to kind of biochemical mechanisms of disease. So that certainly plays a role in people's kind of concern about seeking care. There was also concerns that were noted that healthcare workers were requesting pay for services that were supposed to be free. The government health system is set up so that patients can receive free care, and Ebola was no exception to that. And so that, this is not a new concern. Certainly this is something that happened, this type of extortion happened pre-Ebola, but I think was certainly exacerbated by an epidemic situation where healthcare workers were underpaid, overworked, and facing really significant health risks to themselves for being where they were. So you can certainly understand how someone would be trying to get a little extra on the side. At the same time, you can understand from a patient perspective the additional strain that would place on a family that's already low income, and then in addition has kind of the threat of this pandemic and the inability to perhaps work their normal job, et cetera. Additionally, travel restrictions were placed significantly, both internationally and locally, which we'll talk about a little bit more. But these travel restrictions significantly limited patient access to seeking care. In Sierra Leone, for instance, there was a 3-day lockdown at one point. And during that time, it was very difficult, obviously, for patients who developed symptoms or who had other indications for seeking care to be able to do so. And finally, the healthcare workforce was dramatically changed by this. So there was a significant decrease in expatriate healthcare staff, which form a not insignificant amount of healthcare workers in Sierra Leone. NGO workers in general, whether they were local or expatriate, were less available due to whether they were being paid or not being paid at that time. There was also significant mortality among healthcare workers, as we discussed. That was considered to be the next wave of Ebola deaths, so to speak, was among healthcare workers. And there were some studies that kind of looked at what implications that was going to have on general healthcare in Sierra Leone following, or in West Africa following the Ebola epidemic. And some of the modeling would suggest that in Guinea, where the epidemic first started, that it was going to increase maternal mortality by 38%, by 74% in Sierra Leone, and by 111% in Liberia. So these are countries that already have high rates of maternal mortality, and the lack of access to healthcare providers due to the epidemic was going to have a really serious impact. Those numbers were essentially based on each country's case rate, the death rate, the proportion of healthcare workers that were already present in the population, all of that kind of to put together an estimate of what the impact might look like. And ultimately, those numbers translate to an additional 4,000 maternal deaths per year. So again, in terms of the mortality among healthcare workers, up to 30% of them were in healthcare providers that specifically were targeting maternal and child health. which again is a large portion of the healthcare workers anyway, but these are kind of specific times when people were at higher risk of viral transmission as well. Okay, so we're going to look at a couple of studies again that looked at some of the numbers associated with response to the epidemic. So this is from a 2016 study that looked at the number of antenatal and postnatal visits, institutional births, and availability of emergency obstetric care, as well as maternal deaths and stillbirths in Sierra Leone. They looked at basically all of the districts and kind of the different hospitals that were designated as providing obstetric care. And what you can see here in the chart really clearly is this change in institutional deliveries that sharply decreases, really mirroring the sharp increase of the Ebola virus. So ultimately, they found an 18% decrease in antenatal care, a 22% decrease in postpartum care or postnatal care, an 11% decrease in women delivering at a healthcare facility, and then a 34% increase in facility-related mortality, as well as a 24% increase in stillbirth. So really, really significant changes were noted at the time of this epidemic in terms of maternal and obstetric care. And you can see that, already their rates of these things are rather low compared to what we would expect. But there was a little bit of a slight uptrend even of institutional deliveries in the kind of months prior to the Ebola epidemic, and then this really, really sharp decrease. And you can see that it's kind of staying down relatively low, even as the Ebola virus is starting to decrease. So it's one of those things that once these hits have come to the healthcare system or people's access to care, it takes a long time for the system to recover and for patients to recover their trust. Interestingly, in this particular study, they found only a slight increase in the number of healthcare providers during Ebola, which is likely due to, volunteer physicians that came both from other places in Africa and then also from the US and Europe. But the overall number of healthcare providers actually decreased because the number of student providers decreased significantly. So nursing schools, medical schools closed during the epidemic. And so the number of students present decreased by 2/3. And in places like Sierra Leone and Uganda, as we'll talk about a little bit later, students actually provide a significant amount of the healthcare workforce. And so that actually ends up taking quite a hit as well. So another study looking specifically at Guinea, again, where the outbreak first started, specifically the region that was actually first affected and most severely hit. Again, looked at pre-Ebola, during Ebola, and post-Ebola. And they included all public hospitals in their study, which served 94% of the specific catchment area and really accounted for the vast majority of Ebola cases in that region. They found that Guinea, similarly to Sierra Leone, Guinea had been having increases in antenatal care, postpartum care, and institutional deliveries in the pre-Ebola period. So you can see the blue line kind of with that essential uptrend in all of those areas. All of these went down significantly during the Ebola outbreak. And you can see that, the rate of decline is certainly much higher than the kind of trend up in the pre-Ebola era. Similarly, they had stagnated trends post-Ebola and never really recovered to the pre-Ebola levels. So you can see again that once things go down, once the healthcare system takes a hit or patients' trust in the healthcare system takes a hit, it takes a while for there to be an improvement in that. Okay, this is gonna take a second. I'm gonna switch over for us to watch a quick video about Sierra Leone's Ebola response.
16-year-old Lamatu is one of only a handful of women who has survived Ebola despite being pregnant. Thank you very much for talking to us today. We appreciate it. But this is not her baby. Lamatu miscarried while she was ill. Now she's caring for this little girl who is extremely sick.
I had a cold at home and my joints were aching. My father knew he couldn't keep me at home, so he sent me here. I was bleeding for 2 hours. No one would touch me. After the bleeding, I was put on a drip. I started to feel much better. Now I am recovered.
Unfortunately, pregnant women are very at risk from dying of Ebola and complications related to Ebola. The prognosis for the babies, for the fetuses, is terrible, and it seems to be a concentration of the virus in the fetus.
On the other side of the capital, a new MSF facility. As well as taking Ebola patients from nearby villages, it will also specialise in caring for pregnant women who could be infected. Not one unborn child has survived from an Ebola-positive mother, according to MSF. It's hoped this first dedicated maternity unit will help change that. Health workers are also at particular risk when delivering babies because of the high volume of infected body fluids.
The delivery moment, it's so high contamination moment that we need as well to take care during the delivery for the health staff as well. Or sometimes to have extra protection, like an incubator where you put your hands in the gloves, then you can do the delivery, or you can really accompany the mother without exposed by some liquid by accident in your skin.
Back with Lamatu, and she is well enough to go home now. But she won't leave little Mamusu, whose condition is deteriorating. Tulip Mazumdar, BBC News, Freetown.
And then one more here.
This isn't the first time Sierra Leoneans have been told to stay indoors as part of the fight against Ebola. This is the capital, Freetown, during a lockdown in September. There are far fewer cases now than back then, dozens each week rather than hundreds. But this is seen as part of a final push to end this outbreak. Like last time, thousands of volunteers will go house to house trying to identify every remaining Ebola patient, as well as those who've had close contact with them. They'll also be reminding people how to stay safe.
Well, at the moment, the city is very quiet. I'm in the area, but I'm picking up reports from across the country. Everyone is following the requirement to stay at home. There's a huge amount of support from the population. Streets are empty. People are being mobilized. Vulnerable communities are being fed by our feeding teams, because keeping people at home for 3 days means you have to cater for the poor.
Teams are focusing on 4 hotspot districts in northern and western Sierra Leone, stretching from the capital, Freetown, all the way to Makeni. Last week, all Sierra Leone's 33 new Ebola cases came from these areas.
We hope very much that this campaign will provide a boost in vigilance and really to combat this complacency, as the case numbers have been declining in recent weeks, and that it's conducted in such a way that is acceptable for people, for the families and for the households who will be participating in this effort.
Governments of all 3 of the worst affected countries say they want to see no new cases of Ebola by the middle of next month. They hope this weekend's exercise in Sierra Leone will help achieve that, but it's a very ambitious goal. Tulip Mazumdar, BBC News.
All right, so we're going to flip back here. So those videos just were kind of a prelude to discussing the interventions that were kind of undertaken by these 3 countries primarily. So a couple of things. First, collaboration between NGOs and the Ministry of Health. Again, this is a weekend health system to start with, and so really relying on that collaboration was critical here. There are a couple of different kind of scenarios where that was really done. One in the southern district in Sierra Leone called Pujahun, there was a collaboration with the Ministry of Health and an existing NGO hospital, not only to treat Ebola, but actually to improve referral systems and transport, which they identified as being a big challenge, and in terms of getting patients where they needed to go, both for regular healthcare and for Ebola, with the idea that this is something that will outlast this epidemic and be able to transform the health system going forward. We saw in the video about the Médecins Sans Frontières treatment center that was actually in a school that was taken over outside of Freetown. And kind of the focus that was placed on taking care of healthcare workers because of that high risk of infection. So utilizing the kind of incubator to be able to limit contact with patients with Ebola, and really setting up intensive kind of screening and triage to be able to separate patients, those with Ebola from those without. And then finally, there was a Partners in Health hospital, also in Freetown, that really focused on improved lab turnaround time because testing was such a limited capacity at the beginning of the epidemic, and really working maternal health care specifically into the WHO guidelines and the Ebola guidelines nationally. They also focused on healthcare worker training, which is again something that will outlast the epidemic and be able to strengthen the system kind of moving forward. There was also the development of significant national programs. So all three of these countries developed some form of an emergency operations center that was designed to improve communication efforts and coordinate response teams and logistics to kind of get things to the hotspots, as was discussed in the video. They also developed integrated disease surveillance and response systems that are now present in most of the districts in these three countries. Again, the design specifically to focus on Ebola, but then expanded to say what other infectious conditions can we be monitoring and what other outbreaks can we be kind of investigating. So now in Sierra Leone, their ESR has been expanded to monitor 28 different conditions, which include things like cholera, having had an outbreak of that prior to the Ebola epidemic, as well as kind of tracking malaria rates and vaccination rates and other things like that. And then finally, frontline field epidemiology training programs were another really significant kind of thing that came out of this epidemic, with a goal of expanding human capacity. So a focus on training surveillance officers, utilizing a mentoring model with the Ministry of Health. So this has been another really effective program. They've significantly increased the number of these kind of field epidemiology folks, which is critical in a place that still suffers from significant infectious disease, not just in the context of this outbreak. There were additionally public health campaigns about hygiene and burial practices. You saw some of the signs up in the video as well, just kind of as they were taking shots across Freetown. That's a very common mechanism of getting health information out there to the public. There was also significant utilization of mobile cellular technology, both as outreach to healthcare providers for education purposes and also for outbreak tracking. So there was a kind of public-private partnership with Airtel, which is one of the major cellular services in Sierra Leone, to send text messages to healthcare workers about Ebola education, and that they were able to use kind of a tracking program for patients who had had outbreaks as well. Most people in Sierra Leone and in Africa in general do have cellular access. They kind of skipped the landline phase and went straight to cell service. So it's very, very common for people to have some form of cell service available to them. And so this is a great opportunity to really increase that outreach. Additionally, we talked a little bit about public-private partnerships with Airtel, but there were a number of additional partnerships for transport of supplies internationally and locally. Again, Airtel with the phone text messages, pharmaceutical companies. There were a number of these kind of partnerships that developed as well. And then finally, the WHO guidelines were another kind of major intervention that focused specifically on pregnant and breastfeeding women in the context of Ebola, kind of, again, to review breastfeeding and delivery options and intervention for fetal behalf and all of those kinds of things, getting those available quickly so that healthcare workers who, especially in West Africa, haven't dealt with an Ebola epidemic before, have some guidelines and frame of reference for how they should be managing things. So we'll transition at this point to talking a little bit about COVID-19 and some of the data that has arisen from that. Obviously, this is newer, more recent, less is published and available, but there's still already a significant amount of data that is available and kind of things that we can talk about in relation to the impact on maternity care. So to preface this segment of our conversation, I was lucky enough to be able to complete a global health rotation elective in March of this year. And so I went to Mbale in Uganda, which is on the eastern side of the country, and is a mid-sized town. It's about 5-hour drive from Kampala, the capital. This was my second time in Uganda. The last time was when I was in medical school, also doing an elective rotation. And I am just really grateful for the opportunity as a global health resident to have been able to participate in that rotation and for everything that was done to kind of help coordinate that. I'm very grateful. This is, the kind of beautiful side of Uganda. At least one of my weekends that wasn't spent at the hospital looks like this. So it was an incredibly beautiful place to visit and to travel. In addition to that, though, it really was a fantastic learning opportunity in terms of developing surgical skills, especially for things that we don't always see here in the U.S. Learning kind of clinical management, especially in the setting of limited resources, and then really an opportunity to work on my teaching skills. So it was a fantastic opportunity. As I mentioned at the very beginning, global health is really about rolling with the punches. And so this was yet another lesson in kind of the unpredictability of working internationally. When I had to unexpectedly return early when the US announced travel bans related to COVID-19 that happened about 2.5-3 weeks into my trip. I am particularly appreciative of the years that I took off of Dr. Spencer's life as he helped coordinate the changes in my travel plans. I know it was a stressful moment, making sure that we were all back in the US safely. So I appreciate that. Looking at COVID kind of from a global standpoint, this map from the WHO shows kind of the effect in terms of rates of cases. So the darker colored countries in Europe and the US and South America are the places that have been most affected. We can see these are numbers updated as of yesterday. The United States with over 8 million confirmed cases and 224,000 deaths so far. And then just to kind of compare with our places in Africa that we've been discussing, Sierra Leone, 2,300 cases confirmed with only 74 deaths, and Uganda with 11,000 confirmed cases and 103 deaths. Obviously, these numbers are not going to be a complete picture, right? We know that testing is different in availability of testing, ability to afford or pay for testing. All of those things are different in these places, but I think it does highlight the ways in which our COVID pandemic has been different from prior epidemics, specifically from Ebola. So this is another one of those world mapper maps that looks fairly distorted, as you can see. Here, the size of the country has been shaped by its population. So a larger population is going to be a larger area showing up on the map to kind of give an idea of population density. And then the colors are representing the COVID mortality rates, so the percent of deaths of all reported cases. So again, the darker colors predominantly in Europe and in the US, and then representing higher mortality rates compared with in Africa that are the relatively lighter colors at least. So just another way of looking at kind of where the effect has been significantly. In terms of global responses, to Ebola or to COVID, so in terms of global responses to COVID, the Lancet relatively early on actually published a pretty scathing review of kind of Western responses to COVID. So you can see here the commentary is that the US and UK governments have provided among the world's worst responses to the pandemic, with sheer lies and incompetence from the former and near criminal delays and obfuscation from the latter. So that's a pretty scathing review. This was in response to the Global Health Security Index that was developed by Johns Hopkins, essentially to rank countries' preparedness for managing a pandemic or an epidemic. Originally, the US and the UK were ranked first and second. And you can see from kind of their scathing response of our responses that maybe that assessment was a little bit incorrect. In terms of the African response, the quote here I think is telling that although it's too early to assess the strength of the COVID-19 response in Africa, African countries, despite limited resources, have also adopted measures worth imitating. Yet relatively little has been heard on the global stage about these efforts or from African veterans of the Ebola epidemics in West Africa and Central Africa. I think the primary take home from this is that we often perceive global health as a Western response to challenges in lower and middle income countries, places that have less resources and have higher mortality rates and all of these kinds of things. But truly, we need to shift our understanding of the way that we think about global health to reflect that this really needs to be more of an exchange and recognition that there is a lot that we have to learn from places who have been dealing with these epidemics, obviously not to COVID, but to other things for longer or in more recent history than we have in the US. So other kind of global responses or things that happened, and some of these apply to the US as well as to other places, but international and local travel bans. As I mentioned, my own time in Uganda was affected by international travel restrictions that were put in place on behalf of the US. By the time I arrived in Uganda, they were already restricting travel from China and kind of asking questions about that on your arrival to the airport. I was extensively questioned about a stamp from 3 years prior in my passport related to China. There were additionally local travel bans, again, similar to our kind of quarantine efforts in the US. Locally in Uganda, at least, there were significant restrictions on traveling outside of your own city, on traveling at night, as well as kind of general recommendations to limit mobility into quarantine. Lockdowns and mandated quarantines, again, seen in multiple places throughout the world. There was also a rapid ramp up of PPE production. Lots of reports of places in Africa of kind of recognizing that global supply chains were going to be disrupted and the need for developing local PPE. One of the residents that I worked with in Uganda, communicated to me afterwards that their amount of PPE, certainly what I saw there was very limited. And so he purchased his own individual personal N95 mask that has been kind of the one that he's had available to him throughout this pandemic. And so the ability to produce and distribute PPE locally has been kind of a really important aspect of this. There's also been a huge mobilization of community health workers for proactive screening and triage, similar to some of the responses that we're seeing in Ebola, and the ability of a lot of places in Africa to kind of ramp up those same responses with people who have already been trained and logistic systems that have already been put in place for managing an epidemic have been, again, able to be rolled out in the setting of COVID. In Rwanda, among other places, there are reports of hand washing stations in public centers and transportation hubs with the goal of increasing kind of personal hygiene, in addition to public health campaigns. Mobile technology, again, has been a big player in terms of promoting education and awareness and tracking outbreaks. And then other places have also made use of volunteers and celebrities to call patients and promote public health recommendations, which I think speaks a lot towards kind of what a coordinated response can look like. In terms of WHO guidance, it's a little bit challenging. One of the things that was been recommended is to postpone routine antenatal or postnatal health visits in health facilities with a focus on transitioning to home-based, phone visits, telemed visits, and limiting the number of visits to really kind of condense everything into a few short visits. To prioritize COVID-related screening, specifically related to tobacco and other substance abuse, gender-related violence, which we recognize is always a little bit of an increase during times of high stress and things like that, as well as mental health. To screen all patients and their birth companions for COVID upon arrival to a health facility. And to prioritize early discharge if a facility, if they're having a facility-based delivery, and if not, to prioritize some kind of prenatal contact or postnatal contact within 24 hours for patients who have home births. All of these things are all good and well in the setting of a place where we have access to some of those, technologies that allow us to do that, where we have a telehealth program that we can follow up patients' blood pressures easily, and where we have, we're able to roll out telemedicine in a relatively fast fashion. Certainly in other places, this is going to be a little bit more challenging, and that's been where some of the criticism of the WHO guidance for maternity care has come from. The last thing that I think is important to recognize about the WHO guidance that isn't specifically obstetric related, but discussing kind of abortion and the recommendation for self-management of medical abortion, actually up to 12 weeks. Obviously, this is contingent on being in a place where abortion is legal. It's contingent on being in a place where patients can have access to those medications without necessarily arriving at a healthcare facility. And there was recognition in the guidelines that delaying abortion may result in more significant morbidity, depending on local laws and regulations. But I think it's important to note that that was also included in their guidelines. And I just thought was an interesting kind of factor to consider that we sometimes brush to the side a little bit as kind of non-essential care. So overall, looking at kind of all of these factors together, the WHO guidelines, again, are great for places that have access. For places that don't, it's a little bit more challenging. And so a lot of what we have seen in kind of the literature on COVID response has been unfortunately similar to what we've seen in the Ebola response, that there are significant gaps in access to care because of lockdowns and quarantines. That there is lots of reported decreased utilization of care from fear of infection and distrust of the health system in general. Diminished health workforce from infection and burnout has been also reported pretty significantly. And that's certainly something that we've seen here as well. Disruptions of global and local supply chains, the overall economic impact of unemployment and food insecurity, again, in places where people are often kind of at the brink already and are living on kind of daily subsistence type jobs, it's a huge impact. There's a shifting of resources away from primary services to emergency response, and then a diminished capacity of an already overwhelmed system. A couple of studies have looked at this more specifically. So again, early on in 2020, there was a model of kind of the pandemic effect on 118 low and middle income countries that looked at the availability of health workers, supplies, equipment, access, all of these things kind of combined in a couple of different scenarios to look at what that impact might look like. And essentially the chart above shows the baseline deaths in blue and then the additional deaths for the three scenarios listed where they're kind of considering the impact of different interventions. You can see on this chart that uterotonics is the major, in terms of supply, like things that can't get disrupted in essential care for obstetrics. Uterotonics is the biggest one. And really the first five actually drive the vast majority of the responses in terms, or the effect in terms of kind of additional maternal deaths. But hemorrhage being such an important cause and also so easy to rectify with uterotonics. The other thing that I want to point out about this is that, again, contraceptive use, although a little bit lower in terms of its kind of effect, is still significant in each of the scenarios. And so ensuring that we're maintaining LARC access and other contraceptive access is really critical here. Additionally, studies have looked at the impact of lockdown. So this is from a study in Nepal that was currently doing a large QI project to implement safer birth bundles in 9 major hospitals across the country. And so they had great data looking at basically 12.5 weeks prior to the lockdown and 9.5 weeks after the lockdown. So that's the vertical line on these two tables. And they found an increased stillbirth rate already within this kind of time period of the lockdowns, increased proportion of preterm births, increased rates of induction and C-section, increased rates of maternal complications, which may be in part because women who are less likely to have complications are staying home, but also likely compounded by the fact that people are presenting later to care due to their desire to avoid the healthcare setting. Increased neonatal mortality, again, likely from some of the same reasons. Decrease in intrapartum fetal heart rate monitoring, which I thought was interesting and I think is most likely related to the fact that healthcare providers are trying to avoid patient contact. And that's one of the things that, as we know from our experience on L&D, keeps people kind of continuously in the room. They did note an increase in healthcare workers' hand hygiene. So there is at least some kind of improvement that was noted from this. And, you know, it's at least something. So transitioning a little bit to what we can learn briefly before we wrap up. What are some of the kind of take-home points here? I have one more video here. We'll see if this will play for us.
While Ebola virus and COVID-19 are very different, we've learned a lot from responding to Ebola that can and must be applied to the COVID-19 pandemic. First, build trust through community engagement. During the latest Ebola outbreak, we found that communities were engaged late, leading to mistrust, misinformation, and fear. For us to control COVID-19, governments need to build trust, and they can do that by painting an accurate picture of the situation at hand and providing clear and consistent guidance to the public on what to do that is based on evidence. Second, women are on the front lines. Around the world, most healthcare workers and most caregivers in the home are women, and they are at greater risk of exposure to the virus. Domestic violence also tends to spike during times of crisis, placing women and girls at this additional risk. Given the vital role of women and girls in their households and communities, we need to support them to ensure they do not experience additional risks during the COVID-19 pandemic. And third, work together for a better response. Governments can't battle an outbreak alone. Neither can health staff and aid agencies. We need everyone, from the United Nations to non-governmental organizations, to businesses, and to you at home to pull together and work in unison. So, how can you help? Aid groups like the International Rescue Committee urgently need funding to help communities fight the pandemic. We're responding around the globe. We're only getting started.
Okay, so we'll pause there. We'll go to the next slide here. Okay, so just to wrap up, I want us to think a little bit about kind of all of these lessons that we can learn and how we can apply them here in the U.S. again with our patient population, and to think a little bit about instead of overwhelming a health system, how we can move towards strengthening a health system. What does it look like if we transition gaps in access to care from lockdowns and quarantines and transition that to mobile interventions that ensure an emphasis on prenatal care and facility delivery? I think, we've done a little bit of that with our telemed approach, but I think continuing in the months and years to come to expand our ability to get outreach to patients that otherwise are going to have limited access to healthcare. What if we change our decreased utilization of care from fear and look at a way that we're kind of doing focused outreach and surveillance programs that will get that kind of community buy-in to gain trust and improve access? I think for us in the US, specifically focusing on our patients that we know are at highest risk. So our patients of color in Wisconsin, our women of color, our rural patients that have less access and further to drive in order to access healthcare. What does it look like to focus our outreach and surveillance specifically on those populations with regards to COVID? In terms of health workforce, what does it look like to recruit and train community health workers, to encourage programs that utilize community health workers? We think of that as a very, I think, African thing, but there are models for it in the US, and there are ways in which it is very, very effective to have members of the community go back to that community to provide and engage people in care. In terms of global and local supply chains, transitioning to improved local laboratory capacity, PPE production, vaccine production, looking at kind of what that transition looks like. In terms of the economic impact, if we kind of transition to thinking about new jobs in the health sector, in manufacturing, and in pandemic response and epidemiology. And then overall, in terms of shifting our resources away from primary services, if we transition that towards improved hygiene practices, which we've already seen is one outcome of this outbreak, both in the US and clearly internationally as well. Improving our triage capacity and our screening techniques for potential infectious etiologies. And then I think kind of the overall, transition towards strengthening the whole healthcare system. A couple of quick thank yous. First to Dr. Rice for giving me the opportunity to speak today, and also for leading a department that cares so deeply both about health equity and about global health. To Dr. Spencer for your compassion and wisdom in leading the residency through this global pandemic, including but not limited to getting your residents back to the US. To Dr. Watlett, Dr. Karnowski, and Dr. Schmuel for your contributions to UW's Global Health Program. We're incredibly grateful, and I'm very grateful for the opportunity to have participated during this during my residency training. And finally, to my husband Andrew for putting up with all of the times that I've made him travel to places without electricity or cell service. I know that I am right at the edge of time, but I'm happy to take any questions.
Great. Thank you so much, Stephanie. This was wonderful. We are, yes, just at the edge of time, but we can probably have one question.
Steph, this is Laurel. I just want to, it's not really a question. I just want to say thank you for an amazing presentation. I just learned a ton. And thank you for staying so calm when you were in Africa and we had to quickly bring you back. And your shout out to Ryan Spencer is well placed. Oh my God. So I don't really have a question other than I feel that this work is so important. We're all stymied right now. For God's sakes, we can't even leave Wisconsin. And I think in the years ahead, I think it's going to be a couple of years, we need to think about this work in the context of our own healthcare system because there's so much opportunity. So thank you. And we do have time for one question. Somebody got a question? I see lots of shout outs, Stephanie. It's awesome.